Welcome to Dental Sleep in 5, Episode 3. My apnea is too severe for an oral appliance. I'm John Viviano. I have no vested interest in any appliance, device, or technology. I maintain a sleep disorders dentistry practice, conduct research, and provide educational programs. Our facility is accredited by the AADSM, and the facility and all our programs are taught to AADSM guidelines. So you're told your apnea is too severe for an oral appliance, but you're struggling with CPAP, wearing it part of the night or not at all. Is this the best medicine has to offer? No. Unfortunately, physicians are quick to dismiss an oral appliance, not only for severe sleep apnea, but often even for moderate sleep apnea. The PAP guidelines, of course, state that PAP is gold standard. They do list alternative therapies, but they provide absolutely no guidance, leaving a big knowledge gap. So patients are unlikely to hear about the oral appliance alternative from a physician, and thus the perceived bias that we see. Patients rarely, if ever, hear about an oral appliance from a physician. Dentistry needs to get this message out. According to the most current oral appliance guidelines, an oral appliance can be considered a standard of care for all severities of apnea if the patient prefers an oral appliance or is intolerant to PAP. Remember, PAP is not a magic bullet. Yes, it works, but regarding adherence, about a third wear it happily all night long, about a third wear it part of the night and take it off partway through the evening, and then a third can't tolerate it or refuse to even try it. Adherence with oral appliance therapy is about 90%, but sometimes residual apnea persists. Adjunctive therapies can help, and that's what we do. We take them as far as we can with an appliance, and then add adjunctive therapies to take them the rest of the way when necessary. But sometimes a patient requires more. They would like to see some proof of concept. Simple option, use a temporary appliance. Use subjective relief of symptoms to give them some proof of concept, or objective resolution as documented through oximetry or home sleep testing. This is not literature validated, but we have the tools to very simply and quickly demonstrate some proof of concept. Then there's the apnea guard. Step 1, select the vertical based on phenotype, deliver the apnea guard, and then select target protrusion. That has been demonstrated in the literature to take them close to their therapeutic optimum position. Of course, you have to finalize that through typical calibration, and then look for subjective resolution and objective resolution based on some type of objective measurement, HST, oximetry, and so forth. And here we have the Matrix Plus home sleep test, developed by Dr. John Remmers, a legend in this field, amongst the first to describe the pathophysiology of obstructive sleep apnea in the literature, and the developer of the first home sleep test device. He was involved in the development of the AutoPAP, and then the Matrix in-lab version of this test, and now the Matrix Plus, which is the home sleep test in the hands of dentists. We make trays chairside and then calculate the full range of motion. The jaw by remote control that is moved forward and back and through the sleep period, and oximetry and airflow is monitored, and a report is generated. The patient is labeled as either a responder or non-responder, and what their target protrusion is. So here we have proof of concept, not only whether the patient is going to respond to an oral appliance, but the target zone where they're going to have to wear the appliance. You can conduct a diagnostic study with this device, or you can conduct a theragnostic study, which is the one I've just described, and together this makes the Matrix Plus. My problem is too severe for an oral appliance. So patient presents, BMI of around 42, 46 years old. As you can see, he stops breathing on his back 171 times an hour, non-supine 118, overall average 139. Now, patient asks me, am I a candidate for an oral appliance? Will it work? How do you answer this question? If a physician looked at this patient, do you think they would even contemplate considering an oral appliance for them? However, the patient's intolerant to CPAP. What do you do? Well, we can go ahead and make it blindly and hope for the best. Or we can actually do an evaluation, look for some proof of concept. This gentleman responded as a responder, although he had to be advanced to 95% of his full protrusion. Now, it took him a couple months to be able to wear it in that position. However, when I sent him home on the home sleep test, he was brought down to below 5. And after rubbing my eyes and taking a closer look, I asked the patient, can you take this home again and do 2 consecutive nights? I just want to double check before we send this back to the physician. And the next 2 nights, he was brought down to below 5, with a very small variance actually between each night. This is the final report that was sent to the physician. Now, do you think that physician called me and gave me a pat at the back? No. Should have. And he should definitely consider, when he's dealing with a CPAP intolerant patient, encouraging him to try an oral appliance and perhaps have a theragnostic study with the matrix before proceeding. No call, no pat on the back. Don't let that discourage you. You're a dentist engaged in this field. Become the patient advocate and make sure that the patients know that these tools are available. When considering oral appliance outcomes, remember, for some, an oral appliance is the full journey. For others, an oral appliance is the beginning of the journey. We have adjunctive therapies for the rest of the journey. And for those seeking proof of concept, we have that covered as well. There's no reason to be discouraged from trying the oral appliance alternative.